The following podcast is part of a certified educational activity titled BTK Inhibition, Transforming the Landscape of Chronic Spontaneous Urticaria Treatment. Access the entire activity and complete the post-test at peerview.com/WQU860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Jonathan Bernstein from the University of Cincinnati College of Medicine. Welcome to this educational activity on the transforming landscape for management of chronic spontaneous urticaria and the role of BTK inhibitors and other novel and emerging agents. Urticaria is a poorly understood and underestimated clinical condition characterized by the sudden onset of itchy wheals with or without angioedema, which usually resolves within 24 and 72 hours, respectively. A wheal has three typical features. It appears as a sharply circumscribed superficial central swelling of variable size and shape, almost invariably surrounded by a reflex erythema. It's associated with itching and sometimes, in more severe cases, a burning sensation. A fleeting nature with the skin returning to normal appearance usually occurs with anywhere between 30 minutes to 24 hours. And this is a really important characteristic because hives are evanescent. They are not persistent longer than this period of time. In contrast, angioedema is a sudden pronounced erythematous or skin-colored deep swelling in the lower dermis and subcutis or mucous membranes. It can be associated with tingling, burning, tightness, and sometimes pain rather than itch. And it has a much slower resolution than that of wheals. It can take up to 72 hours to resolve. Urticaria is classified based on duration and the relevance of eliciting factors. It's considered acute if it's occurring less than or equal to 6 weeks, and chronic if it occurs longer than 6 weeks. It's classified as spontaneous, meaning no specific eliciting factor is involved, or inducible, meaning there is a specific eliciting factor involved. So the definition of chronic spontaneous urticaria is appearance of wheals, angioedema, or both for over 6 weeks because of a known or unknown cause. Whereas the classification of inducible urticaria is really defined by a specific eliciting factor, which can be cold, delayed pressure, solar, heat, vibration, again, changes in core body temperature referred to as cholinergic urticaria, contact urticaria, and in very rare cases, aquagenic urticaria. The most common form is dermatographism, which basically means to write on skin, where you stroke the skin and it welts up within 2 to 3 minutes. When we look at chronic urticaria, we have to be aware that there are other associated clinical symptoms in addition to just the skin manifestations. Patients can present with joint pain, headache and fatigue, flushing, breathlessness, gastrointestinal symptoms, and palpitations. Of course, one wants to make sure that patients don't have other underlying problems going on or have evidence of something like systemic mastocytosis. But suffice it to say, patients with uncomplicated chronic spontaneous urticaria can have these types of symptoms as well. The prevalence of chronic spontaneous urticaria is anywhere between 1% and 5% in the general population. Women are twice as likely as men to have chronic spontaneous urticaria. And usually hives develop most commonly between the ages 30 and 50, although some have quoted 20 to 40, but it can develop at any age. But these are the most common age ranges that we would see in the United States. In some countries, reports of onset of urticaria has been in younger age ranges, but this is really more relevant for the United States. People who have chronic spontaneous urticaria and develop angioedema associated with it tend to have longer lasting symptoms compared to just urticaria alone. And this is a marker of severity as well. Again, in general, chronic spontaneous urticaria lasts anywhere between 1 and 5 years, although it can last much longer and even decades. We see a pictorial of the breakdown of hives. Typically, about 57% of patients only have hives, about 37% may have hives with angioedema, and about 6% may have only angioedema. Now, these numbers can vary depending on the population studied. Now, when we think about the pathogenesis of chronic spontaneous urticaria, mast cells and basophils are key drivers. Activation of mast cells and basophils results in histamine and cytokine release with subsequent dermal inflammation. The dermal mast cells express many activating receptors and a few inhibitory surface receptors, which are believed to be responsible for their activation. The number and variety of surface receptors and their respective ligands make dermal mast cells uniquely sensitive to changes in their environment. And this is illustrated in this pictorial, which shows a mast cell with many different types of receptors and how they can be activated by different potential triggers. When we look at the mechanisms of mast cell activation, there's two overlapping mechanisms of mast cells and basophil activation have been proposed. Both mechanisms involve cross-linking of the high-affinity Ig receptor, referred to as Fc epsilon receptor 1, and activation of downstream signaling pathways, and they may co-occur in the same patient. So we refer to these two conditions as type 1 autoimmunity, which occurs via IgE against the various autoallergens, and this has been demonstrated for several different autoallergens, including thyroid peroxidase, and type 2B autoimmunity, which is mediated predominantly via IgG antibodies directed against the Ig receptor, Fc epsilon receptor 1, or the Fc epsilon receptor bound IgE. Now, there continues to be unmet needs in chronic spontaneous urticaria. There's a delay in diagnosis. The average time from symptom onset to diagnosis is approximately 2 years. Patients try to treat the disease before seeking medical care, and symptoms may not be occurring when the patient visits their healthcare professional, so they may not recognize it as chronic urticaria. And again, there is also a complex differential diagnosis. So there are conditions that present as hives that are not the classic chronic spontaneous urticaria condition. There's types of hives that are refractory to standard therapy. This includes the second-generation antihistamines, which are considered first-line therapy, as well as omalizumab, which is a monoclonal antibody that blocks IgE antibody in the peripheral circulation and downregulates Ig receptors on mast cells. Again, there's many patients who are not well controlled, even at increased doses of these medications. Approximately 40 to 45% of patients respond to antihistamines, but many do not. And this is where there's a need for novel therapies. So how do we approach the management of chronic spontaneous urticaria? This is a nice algorithm that we like to implement with every patient we see who presents to our clinic. And we ask questions about the nature of the hives. We recommend a physical exam to determine do the hives look appropriate? Are there inducible components? Can we do provocation like stroking the skin to see if there's dermatographia? And we also like to use patient-reported outcome measures that are validated, like the Urticaria Control Test, to see how well controlled patients are at the time of their visit. And theoretically, as patients are responding to treatment over time, the Urticaria Control Test should improve as well. So we confirm the diagnosis, we rule out underlying causes, we look for causes, we look for indicators of chronic spontaneous urticaria because of autoimmunity type 1 and autoimmunity type 2B. We look at cofactors, identify potential triggers and aggravators. And we also look at comorbid conditions. We check for chronic inducible hives, we look for autoimmunity, and certainly try to assess mental health status, such as anxiety and so forth. But there's been many studies that show that there's even a higher prevalence of allergic diseases in patients with chronic urticaria. We look at the consequences. What impact is it having on their sleep? Is it causing a lot of distress in their daily lives? What impact does it have on their sexual health, their interpersonal relationships, or their work and social performance? And we also want to look at the components. We want to assess potential biomarkers or predictors of treatment response. And finally, we want to monitor activity over time and what impact it's having and the control patients are exhibiting after treatments have been implemented. This is a diagnostic algorithm for chronic urticaria, which is in the most recent international guidelines for urticaria. And it starts off by asking, does the patient have wheals, or does the patient have angioedema, or both? And if they have recurrent unexplained fever, joint bone pain, or malaise, we want to think about other conditions like autoinflammatory diseases. And these patients, they have other conditions like acquired hereditary autoinflammatory diseases, and these need to be ruled out. But there's other causes in the differential diagnosis that need to be excluded. If they don't have this, then we want to also think about the duration of the wheal. Does it last longer than 24 hours? If it does, one wants to consider a biopsy to rule out vasculitis, as urticarial vasculitis lesions tend to persist longer than 24 hours. If the patient's on a medication like an ACE inhibitor and they're having swelling, is this an ACE-induced angioedema? Does the swelling go away after stopping the medication? And then the other question is, are the symptoms inducible? We can do provocation tests to determine if it's positive or negative. This will lead us to the final diagnosis of whether somebody has chronic inducible urticaria or chronic spontaneous urticaria, or both, and exclude some of these other less common problems like hereditary angioedema, and also a more common problem like ACE-induced angioedema. So this comes back to this confirm part of our initial assessment of our patients. And again, the differential diagnosis of urticaria is listed here. There's many different conditions. I mentioned urticaria vasculitis. I mentioned HAE, which is a bradykinin-mediated form of angioedema, but other conditions like cutaneous mastocytosis or mast cell activation syndrome, which presents with many of the same symptoms. We talked about the autoinflammatory diseases, but copyrin-associated periodic syndromes are a spectrum of these conditions. Something like Schnitzler syndrome, which is recurrent urticaria rash and a monoclonal gammopathy. These patients also have recurrent fever, bone and muscle pain, and arthralgias, and also associated with lymphadenopathy. Gleich syndrome, which is very rare, but episodic angioedema with eosinophilia. Wells syndrome with granulomatous dermatitis with eosinophilia or eosinophilic cellulitis. Bullous pemphigoid, as well as adult onset Still's disease. So when we think about the next step, it's cause, determining the underlying cause. And the recommendations are that physicians should explore patients with CSU for underlying causes by asking relevant questions or by using more specific tests where indicated and available. It is recommended that specialists should measure total IgE as well as IgG antithyroid peroxidase, and if available, use basophil testing to assess patients with CSU for type 1 and type 2B autoimmunity. Cofactors that should also be considered, and these are relevant conditions that can modify disease activity, and this might include food or drug intolerance, stress, or chronic infection. Comorbid conditions, as I mentioned, thyroid disorders such as Hashimoto's thyroiditis. We want to ask patients about that. This tends to be more common in women, but can occur in men as well. And we ask about signs and symptoms suggestive of hyperthyroidism or hypothyroidism. And if one suspects this condition, a TSH with a free T4 is indicated. And as I mentioned, getting antibodies against thyroid peroxidase is recommended. And we'll talk more about why that's important in a moment. Asking about mental disorders and doing some assessment, because this can certainly affect quality of life and chronic urticaria quality of life, as patients with this condition can get quite distressed and depressed about this condition because it's very disruptive to everyday life. And then talking about inducible hives, can you make the wheals occur with physical stimulus? And there's a number of provocation tests that can be used to induce urticaria in these patients. What about consequences? Well, here we see the burden of disease as a substantial burden. It causes embarrassment because patients have welts all over the body. They go into their office and they say, are you contagious? There's a lot of stress and anxiety and depression, as I've mentioned. There may be social isolation, sleep disturbances, and significant difficulties with work and school impairment. Components that are useful to measure the prognostic biomarkers that have been recently identified with longer duration, higher activity of hives, and or response to treatment. These lab tests in chronic spontaneous urticaria features may be linked to long disease duration, such as an elevated IgG against thyroid peroxidase or a high CSU severity or activity score at the time of presentation. Parameters or biomarkers linked to higher CSU activity may also include D-dimer levels or C-reactive proteins. In fact, patients who have a high C-reactive protein may also not respond as well to second-generation antihistamines. Again, CSU parameters, biomarkers linked to poor response to treatment include the CRP, but also the presence of concomitant chronic inducible urticaria, having a positive autologous serum skin test, which is a surrogate marker for autoantibodies directed against IgE receptors on mast cells. And of course, having a high urticaria activity score, as we've talked about. Other parameters linked to poor response to omalizumab include a low IgE. Some have quoted less than 40 international units. Others have looked at it even lower, less than 20. But suffice to say, when they're lower, there's less of a response to omalizumab. A positive basal histamine releasing assay. These are serologic tests that can be used to measure surface expression of CD203 and CD63 on basophils to see if these patients will have these. It's again a surrogate marker for antibodies targeting against the high-affinity Ig receptor. CSU parameters or biomarkers linked to good response to cyclosporin treatment include a low total Ig and a positive basal histamine releasing assay. So these tools, these biomarkers have been shown to potentially have a good benefit for discussing with patients what the best treatment course would be based on their biomarker profile and what they can expect in terms of treatment response. So what is the course? How do we assess disease activity, impact, and control? Well, we use validated instruments, and one instrument is the UAS and the UAS-7. The UAS-7 stands for Urticaria Activity Score that's measured each day over 7 days, and it's been validated for assessing disease severity in CSU. The scores can be measured once a day. Originally, it was developed twice a day, but now they validated it so it can be used once a day. And there's also now a validated score. You can use the UAS score just over 1 day. And basically what it is, it's a composite score of wheals and itch. And you can see a score from 0 to 3 based on severity. So wheals may be a score of 0 for wheals if there are none. And 1 is if there's less than 20 wheals over a 24-hour period of time. 2, if there's 20 to 50 wheals over that period of time. And if it's intense, with a score of 3 over 50 wheals over a 24-hour period of time. And similarly, itch is categorized as mild, moderate, and intense. And you add these numbers up, the total score for each day would be 6. And then if you use this over a 7-day period, the total score would be 42. And so if someone is very poorly controlled, they would have a UAS-7 of 42. And the idea is to try to get them to be very well controlled and have a UAS-7 of 0. And the UAS-7 is used in clinical trials because it has been FDA approved as an endpoint for assessing impact of therapies on chronic spontaneous urticaria and chronic inducible urticaria. So this is just showing the international guidelines, which looks at the treatment approach. And you want to start with a standard dose of second-generation antihistamines. And if the standard dose is not effective, you can increase it to up to 4 times the dose. And this is a consensus recommendation based on expert opinion, and it's very safe. If we don't see a good response after 2 to 4 weeks, then it's recommended to add to this regimen omalizumab, which is the IgG antibody against IgE, which has been shown to be very effective in treating chronic urticaria. In fact, controlling urticaria completely in 45% of patients. And there's some question whether or not the dose should be increased or the interval shortened, although there's less evidence to support that. And if this is not well controlled, then within 6 months or earlier, one may consider a medication like cyclosporin. So this is a very simplistic algorithm, and there's a lot of nuances because not all patients are the same, and one has to really get a good history and determine where the best place to start and what the next steps should be. But this is based on great evidence, and this is why these therapies are included in this sequence. So chronic spontaneous urticaria is typically treated with antihistamines, but as I mentioned, it can be uncontrolled in up to 50% of patients. They may not respond, so we need to have additional safe and effective alternative treatment options. Now I'd like to pivot and talk about some of the newer therapies that are being developed for chronic spontaneous urticaria, and this would include BTK inhibitors. This is a therapeutic targets for CSU, and you can see there's a central role for BTK in terms of regulating mast cell activation. There's been many treatments that have been targeting different receptors on mast cells, looking at treatments that target the alarmins like TSLP, barzolvolimab, which is targeting c-KIT receptors, lirentelimab, which is targeting cyclic 8, although the targets now are cyclic 6. The cyclic 8s have not been shown to be as effective. And again, omalizumab, which is the classic therapy, which has been available since 2014. But BTK has significant effects, and there's now at least 2 agents that are BTK inhibitors that are being developed for the treatment of urticaria. This is the approved omalizumab, which, as I mentioned, has been approved since 2014. But here it includes dupilumab, which targets IL-4 receptor alpha, and it already has approval for many different indications, but not yet chronic spontaneous urticaria in the United States. Remibrutinib, which inhibits BTK, which is in phase 3 development. Rilzabrutinib, which also inhibits BTK in phase 2 trials. Benralizumab, which targets IL-5 receptor. However, it is approved for asthma, but was not successful in clinical trials for chronic spontaneous urticaria. Tezepelumab binds TSLP, and it's approved again for asthma, but not for CSU, and it's unclear whether they'll be moving forward with this agent for this indication. I mentioned lirentelimab, which is a cyclic 8 antagonist. It's not approved. Those studies were not successful. Current studies are looking at cyclic 6 antagonists, and so they're early on in their development. And then there's barzolvolimab, which again is an anti-c-KIT, and that's further along and starting in phase 3 trials. And then secukinumab, which binds to IL-17. Again, it's approved for other indications, and it's not yet approved for urticaria. Now, when we think about omalizumab for refractory chronic spontaneous urticaria, this is the studies that were used. Phase 3 clinical trial program consisted of 3 randomized double-blind placebo-controlled studies in patients with moderate to severe H1 antihistamine refractory hives. And again, the Exterior-1 was a 24-week program, which was a dose-ranging study of 75, 150, and 300 versus placebo. There were 6 treatment visits. After that, there was a 16-week follow-up. And patients had to be on approved doses of H1 antihistamines, which were not effective at controlling their hives. Now, the design for Exterior-2 is very similar, except it was a little bit of a shorter study. It still was dose-ranging, but it was a 12-week period, and it was, again, a 16-week follow-up. The interim analysis for each of these, or the primary endpoint for each of these, was at 12 weeks. And then Glacial, again, enrolled patients to 4 times the dose of H1 antihistamines, or doses of antihistamines plus leukotriene receptor blockers, or H2 antihistamines, or they could be on all 3 in combination. And again, this was a 24-week period with just omalizumab, 300 milligrams versus placebo, and a 16-week follow-up. But all of these, again, the primary endpoint was at 12 weeks. And you can see the proportion of responders in the Exterior 1 and 2 trials. You see that compared to placebo, omalizumab 150 improved in over 41% of patients. And this is patients with a UAS-7 score of less than or equal to 6. So they weren't completely clear, but they were significantly improved. And you can see there was a greater effect in the omalizumab 300 milligram dose. And we see similar results with the Glacial study. And then when we look at the UAS-7, where there are no hives, again, you see 40% of patients in Exterior 1 and 2 had no hives at the end of 12 weeks. And again, much greater effect than you see with omalizumab 150, but both were greater than placebo. And again, Glacial reflects these findings. Now, there's been some studies looking at dupilumab, which again is an IL-4 receptor alpha blocker. And again, design was in adults and adolescents, 12 years of age and older. The diagnosis of chronic urticaria refractory to H1 antihistamines, a randomized double-blind parallel assignment, placebo-controlled study. Patients in study A were omalizumab naive, and in study B, they were intolerant or incomplete responders to omalizumab. Both studies had two arms, dupilumab versus placebo, and these patients all had to be unresponsive at non-sedating H1 antihistamines. The primary endpoint was itch severity score, and the secondary was urticaria activity score, hive severity score, and there was also an angioedema activity score, urticaria control trust quality of life, and several other assessments were made. And you can see that in study A, which was Cupid A, there were 138 omalizumab naive patients enrolled, and there was a 63% reduction with dupilumab versus a 35% with standard of care antihistamines. This was a 10.24-point reduction with dupilumab and a 6-point reduction with standard of care. So this was quite significant. There was also a reduction in the urticaria activity severity versus standard care, a 20.53-point reduction with dupilumab versus 12-point reduction with standard of care. And it was relatively safe. Treatment emergent adverse events were similar between the two groups, and the most common adverse events were injection site reactions. Now, in patients who were in the study B, Cupid B, this was 83 patients who were intolerant or incomplete responders to omalizumab, and they looked at this during the 24-week treatment period. Patients received dupilumab or placebo every 2 weeks, added to standard of care antihistamines. However, they did not reach statistical significance in interim analysis despite numeric improvements observed across key endpoints. And so this study was abandoned. It was discontinued due to futility. So there is a Cupid C that's ongoing, and we expect to have those results in the next year and likely an approval for this drug at that time. And the efficacy is similar to Cupid A study, where we're looking at dupilumab and CSU refractory H1 antihistamines in omalizumab naive patients. There's also a LIBERTY-CSU Cupid Kid study estimated to complete in 2025 for children between 2 years of age and older and less than 12 years of age. Now, remibrutinib has been investigated with the REMAX-1 and the REMAX-2 phase 3 trials, and this is the study design of these two phase 3 randomized placebo-controlled studies, dosing with remibrutinib 25 milligrams twice a day, administered orally. And you can see adult patients with a diagnosis of CSU for 6 months or longer, inadequately controlled with second-generation H1 antihistamines, were qualified to be enrolled. They were randomized 2-to-1 to receive active drug or placebo. The primary endpoint was change from baseline in UAS-7 at week 12, and the other scenario was change from baseline in itch severity score 7 and hive severity score 7 at week 12. Secondary endpoints were percentage of patients with a UAS-7 less than or equal to 6 and a UAS-7 of 0 at week 12, and then also the percentage of patients with a UAS-7 less than or equal to 6 at week 2, and occurrence of treatment emergence and serious adverse events during the study. And you can see that the study design, the primary analysis was at 24 weeks. The primary endpoint was at 12 weeks, and it was a 52-week study, but there was a follow-up extension as well. And what we see here in both studies, there was a significant improvement in UAS-7 score from baseline, and for REMAX-1 and REMAX-2 for remibrutinib 25 milligrams twice a day versus placebo. And this was quite significant through the duration up to the time that the primary endpoint was analyzed. There was also a significant change from baseline UAS-7 at week 12 compared to placebo. You can see that the patients who had anti-IgG biologic exposure had a significant improvement, but also patients who had anti-IgG biologic naive also demonstrated significant response. So this is very interesting, and of course suggests that this BTK inhibitor is having a more profound effect on different pathways, as both of these types of patients, responsive and unresponsive to anti-IgG molecules, are showing a significant effect. And this was reproduced in Remix 2 study. So the change in baseline UASM was greater with remibrutinib versus placebo at week 12, regardless of prior exposure to anti-IgE biologics at baseline. And this is looking at week 12, the complete responders, and you can see that 33.7% of patients who were exposed previously to anti-IgE and 29.4% of patients who were anti-IgE biologically naive had complete response, no hives at the end of 12 weeks. And very similar numbers were seen, 29.2%, 27.4% respectively for the anti-IgE biologic exposed and biologically naive patients at the end of 12 weeks. So very consistent data and much more significant than the placebo arm. What about safety? Well, you look at the remibrutinib versus placebo, you can see that the overall adverse effects were very similar, 64% for remibrutinib, 64.7% for placebo. Infections were the most common reported. Again, no difference between groups. Serious adverse events, again, there were 20 for remibrutinib and 7 for a placebo, but when you look at the percentages, they're very similar. And serious infection adverse events, very similar between groups. With respect to adverse events leading to treatment discontinuation, there was no difference between remibrutinib and placebo, and there were no deaths reported. So I think that it's very important data because what we're seeing here is that remibrutinib appears to be very effective regardless of patients who have autoimmune urticaria, chronic autoimmune urticaria, or have the autoallergy form of urticaria versus the patients who don't have these characteristics but aren't responsive to H1 antihistamines. The fact that it's oral and safe would suggest that this potentially could be a first-line treatment after the use of second-generation H1 antihistamines at high doses at 4 times the recommended dose. Now, there's also another BTK inhibitor, rilzabrutinib. There's studies underway. It's a randomized. Now, I'd like to pivot and talk about, some of the other considerations in the management of chronic spontaneous urticaria. Now, we recognize that from all the consensus opinion, the goal of treatment is to treat chronic spontaneous urticaria until it's completely gone and as efficiently and as safely as possible, aiming for a UAS7 of 0. So this would indicate complete control. You would, as a result, would have normalization of quality of life. Again, we talked about avoidance when it's possible of inciting agents and so forth, but the therapeutic approach really does require use of pharmacologic treatment to prevent mast cell mediator release or the effects of mast cell mediators. And we certainly want to use the least amount of medication necessary to achieve control and then step up or step down depending on control of disease over time. So these are some of the same principles we use for any condition that we're managing, whether it be hives or asthma or rhinitis. So in doing so, we look at this nice pictorial, which is the assess, act, and adjust algorithm. And so when we assess, we look at other diagnostic procedures, we assess comorbidities, we look at severities we've talked about. We also have to address patient preferences and values about what type of treatment they'd be willing to receive. And we also want to take into account adverse effects, adverse events of treatment. Then we want to act. We want to start therapy. Then we want to modify treatment, and treat comorbidities. We want to educate the patient about the treatment, about what they can expect in terms of response to treatment. And this is helpful with the use of the biomarkers we've discussed that can be useful in that discussion because there's, some characteristics that would predict patients may not be as responsive to antihistamines or omalizumab and so forth. And we want to educate the patient because an educated patient is an engaged patient and an adherent patient. And then we want to, again, adjust medications up and down depending on control over time. And we use these validated control measures, the urticaria control test, to really assess the control level and determine, do we need to increase therapy, decrease therapy, or stay the same? But we want to establish control for at least 3 to 6 months before we start stepping down. So these are the principles for patient charter for improved chronic urticaria care. I deserve an accurate and timely diagnosis of my chronic urticaria I deserve access to specialty care for my chronic urticaria. I deserve access to innovative treatments that reduce the burden of chronic urticaria in my daily life. I deserve to be free of unnecessary treatment-related side effects during the management of my chronic urticaria. And I expect a holistic treatment approach to address all of the components of my life impacted by chronic urticaria. This is not unreasonable asks for a patient in terms of wanting to have, excellent control of their chronic urticaria. Look at the patient treatment goals. This was, again, a study that was published a few years ago, and what was important to the patient. And again, very important is outlined in green, quite important is in lighter green, and then moderately important is yellow, and then somewhat important in orange, and not important at all is in red. And again, there's some non-applicable criteria as well. But you can see the most important criteria are have more visible skin changes, be free of itching, be healed of all the skin defects, find a clear diagnosis and therapy, be less helpless against the disease, have confidence in the therapy, have no fear that the disease will become worse, and be less dependent on doctors and clinic visits, no longer have burning sensations on their skin. And this goes on that these are some of the most important things. So they all point to really improvement in their quality of life. So patient education, shared decision-making is critical in chronic spontaneous urticaria. Patients should be informed of the potential for response to treatment, the potential for side effects of the treatment, and they should be part of the decision-making process whenever possible. The discussion of the patient's treatment goals is also a key part of shared decision-making, and we want to address all components of a patient's life that are negatively impacted by chronic spontaneous urticaria. And this can be done by assessing their quality of life using validated quality of life questionnaires. We want to look at patient-reported outcomes such as UAS7. It should be included in monitoring disease activity and treatment response, along with available biomarkers, as we discussed, that can help predict response to different treatments, as well as clinical characteristics that may also have a predictive value for severity and response to treatment. We also want to consider patient-specific barriers to treatment adherence, such as cost, side effects, as this is an important part of treatment selection and optimization. So it does require multidisciplinary care. We need to consider a number of different underlying comorbid conditions that need to be managed, such as asthma, allergic diseases, and so forth. We want to take into account psychiatric and medical disorders, and we want to rule out autoimmune conditions that are much more prevalent in patients with chronic spontaneous urticaria. So it may involve the input from dermatologists, from allergists, immunologists, primary care doctors, even mental health care professionals, rheumatologists, endocrinologists, and other specialists. So in conclusion, only up to 40 to 50% of patients with chronic hives respond to high-dose antihistamines, so other treatment options are needed. Biologics have opened up the field of urticaria and provided some additional treatment options and have been very effective in treatment of patients with chronic spontaneous urticaria. They have improved hives remarkably. There are newer therapies such as BTK inhibitors, specifically remibrutinib, which has the potential to become a novel oral treatment option that may address unmet needs of patients with CSU, inadequately controlled by second-generation H1 antihistamines. And we saw from some of the studies, these are also patients who might respond who have not responded to other therapies like omalizumab. The challenge is to define specific phenotypes and corresponding endotypes with point-of-care biomarkers that can lead to more targeted therapies. Many other biologics are in development, so this hopefully will lend to more knowledge about these predictors, these prognosticators of chronic spontaneous urticaria. And we are beginning to have a whole new understanding of chronic spontaneous urticaria with the development of these novel therapies. So this ends our discussion for today. I hope you found the activity interesting and useful to your practice. Thank you very much for joining me.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/WQU860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation.